G'day, I'd like to let you know that Aussie Med Ed is sponsored by Tego. For most doctors, indemnity insurance is one of their biggest costs of practice. While many doctors are still with the same insurer they joined in medical school, many have made the switch to Tego and benefited from it. The team at Tego have told me that those new to private practice could qualify for 4 years of discounted premiums. To find out more about Tego, visit tego.com.au. That's tego.com.au. Good day and welcome to the Aussie Med Ed, the Australian Medical Education podcast, where we get to interview specialists in a variety of medical areas, asking their opinion on their certain conditions and obtaining their insight into how they diagnose and treat that condition. In these COVID times, it's a way of replacing the relaxed discussion around the hospital by allowing the listener to put forward questions to be answered or addressed on their behalf. I hope you enjoy the whole program and welcome once again to Aussie Med Ed. And in this episode, we get to interview Dr Shaun Fowler, a radiologist who specialises in musculoskeletal imaging. Shaun is going to talk to us about radiological investigations for musculoskeletal conditions, outlining what can be ordered and how they actually help our diagnosis. Not only will this information be useful for the general practitioner seeing a patient on a regular basis, but also for the medical student revising for their exams or preparing for their OSCE examination. I'm Gavin Nimon. I'm an orthopaedic surgeon based in Adelaide in South Australia and a senior lecturer at the University of Adelaide, and I'm the host of this podcast. Remember that if you like the podcast, please don't hesitate to share it with your friends or give us a review on Apple or on Spotify. I'd like to begin this podcast by acknowledging the traditional custodians of the land on which this podcast has been produced and pay my respects to the elders both past and present. Well, now I'd like to welcome Dr Shaun Fowler. He's a radiologist who specialises in musculoskeletal imaging, and he's the director of Fowler Simmons Radiology in Adelaide. He initially graduated from Adelaide University and was dux of his medical year. He trained at the Royal Adelaide Hospital in Radiology and then moved to the United States where he had a fellowship in musculoskeletal imaging and vascular intervention. He co-established Fowler Simmons Radiology in 2012, which is a specialist musculoskeletal imaging radiology group. He's married and has 5 children and enjoys golf and wine along with relaxation with the family. Welcome, Shaun Fowler. Very nice having you on board.
Thanks for the invite, Gavin. I appreciate the opportunity. Very happy to be on it. Thank you.
It's great to have you on board. I like to encompass a whole lot of different areas of medicine, and radiology is a particular area of interest of mine, given that I'm an orthopaedic surgeon. I'm always ordering investigations, but really want to know what sort of investigations you think are most useful in musculoskeletal imaging. Could you go through the main imaging modalities that you provide at Fowler Simmons and which ones have the main merits?
Look, I think they all have their place. We offer obviously a combination of X-ray, ultrasound, CT and MRI. The main modality that we don't have is nuclear medicine, and that has a role, but maybe becoming a lesser role in musculoskeletal over the years where MRI has taken its place. But we see obviously lots of standard private practice type presentations for musculoskeletal discomfort and derangement. And I think they all have their value, but it really depends on the presentation, to be honest. Certainly in some instances, you'd be obtaining an X-ray because it's a fairly basic question, and then other times the MRI is the more appropriate one. Did you have specific clinical presentations that you felt that I should be discussing?
I like to start with speaking to the medical students, are saying probably the X-ray is probably the most useful test across the board, not always for the specific area, but specifically for the joints and particularly in shoulders and knees and things. I find X-ray straightforward.
And I think you can certainly sometimes get away with just an X-ray alone. There are plenty of patients who have severe groin pain or severe knee pain and they're in the right age for osteoarthritis, etc. And an X-ray alone is going to tell you that this person has a very worn-out knee and it's probably their presentation relates to osteoarthritis. But that being said, I'll see plenty of patients who have an acute deterioration of what has been a long-standing, let's say, osteoarthritis of their knee. And to obtain an X-ray alone, you might be misled thinking that's the cause for their current exacerbation of symptoms. And that can be variable, and obviously that's where the clinical history, et cetera, comes into it, because I see many people who have a nasty episode of quadricep tendinosis or gout in their quadricep tendon where the X-rays will give you the impression that it's their osteoarthritis, and then the other modalities sort of lead to a more specific diagnosis that explains their acute deterioration. But yeah, certainly X-rays is very useful as a starting point to exclude some significant pathology and also to give you some information as to whether there's any sort of anatomical variation that may be predisposing to the current presentation as well.
So it's a straightforward, easily organised investigation. What about the risks of radiation when you organise most X-rays? On average, are those risks significant or are they less of an issue nowadays?
Look, I think the dosage is obviously always important and more important in the younger individuals, and I think you need to take that into account when ordering any imaging that involves radiation. But that being said, most of in the musculoskeletal system, if you're doing extremity work, the knees, ankles, wrists, and elbows are pretty much risk-free to a degree because of their position in the extremity and their lack of exposure to vital organs. But I think when we're getting into sort of lumbar spines, thoracic spines, shoulders and hips, that's where the dose is. It's certainly a little bit high. You've got to sweep through a little bit more tissue, and I think you need to take that into account when you're ordering them. You certainly don't want to be ordering them willy-nilly. There are those patients who do need imaging of the spine, say for follow-up of scoliosis, and there are sort of techniques now to try to reduce the dose on those sort of individuals so that you can get the diagnostic information with as minimal dose as possible.
What about the risk in a pregnant individual, say for X-raying like a knee or a wrist? Can that be screened out to protect the fetus, or is that still something that we should avoid?
When you're exposing anyone, the risk-benefit analysis needs to be done, and it becomes even more acute when you're assessing a pregnant female. My main concern is going to be in that sort of 8 to 12 week stage, which is that period where of pregnancy, that is, where organogenesis is occurring and the risk is at its highest stage. Once you get along 12 weeks, the risks are less, and certainly before 12 weeks, 4 8 weeks, the risks are somewhat less as well, at least of malformation. That being said, a wrist, an ankle, the dose is going to be very low, and typically you'd be healed in the area of concern. You wouldn't be doing it for just a general wrist ache. In the setting of acute trauma, and you need to know whether there was a fracture, otherwise the benefit would outweigh the risk.
And when ordering X-rays, obviously most medical students will know to organise an AP and lateral of an X-ray or try to get 2 views. What are the main joints or regions that you need to order something different, or does it really matter that much when the radiographer and the radiologist can then determine what images are required anyway?
I think most areas there will be a standard protocol for obtaining a standard series of images, and that may involve an oblique, that may involve a PA at 25 degrees off leg or equivalent. Shoulders often have 4 views with an axillary view. So I think in standard ordering of X-rays, I think if you're being clear as to what you're ordering it from, and I think sometimes what you might order in the emergency room for acute trauma might be very different from what you order in the setting of chronic shoulder pain. I tend not to worry too much about requesting the views. I think providing the appropriate clinical information and providing the area of interest is probably more relevant. So if you're interested in the midfoot, make sure you order the foot. If you're interested in the ankle, make sure you order the ankle. But if you're interested in both the midfoot and the ankle, order both. But because if someone sprained their ankle and they've got a Lisfranc injury rather than an ankle injury, then you're probably not going to pick that up on a standard X-ray of the ankle. So you just got to give where you think the abnormality is and make sure you're asking for that area to be X-rayed.
So the important information really is to give enough clinical information, provide the area you're concerned about, outline whether the patient could possibly be pregnant or at higher risk, and also, I presume, I think we've talked about this in the past, Shaun, to provide if any other X-rays have been provided or any other investigations have been done in the past are probably the most useful things. Is that correct?
Yeah, look, I think it's always nice to know if there's relevant clinical history, whether they've had previous surgery in the area or previous imaging of that area, because if we're aware of it these days, for the most part, we can track it down and make a comparison. And I think often the most useful thing we can say is that it's either unchanged or progressed from previous studies. So if you provide good clinical information and then you place the correct region on the request form, the appropriate series should usually be obtained.
If we can just run through quickly the ones that I think might be a little bit unusual, such as a clavicle fracture or an AC joint injury, what X-rays are they? AP and 15 degree up tilt for you for those?
That would be the standard series for a clavicular fracture. But if you were to keep it easy and you didn't want to remember which views are obtained, if you just said crude clavicular fracture, then the protocol is written down in all of the X-ray rooms for obtaining that in that setting. So cover the area, we should know what the views are. The orthopaedic surgeon may have a different demands for different things, and they may want a different view of the femoral head neck junction of the hip, etc., and they'll write those views down. But if there's nothing specific and you're looking for either a cause for their pain or for exclusion of fracture, just covering the area should be enough.
And so obviously concerned about a wrist and worried about a scaphoid fracture. Mention that as well to get the scaphoid series.
Yeah, that's correct. Yeah, look, a standard wrist series doesn't always include a specific scaphoid view. I don't know why, but it often doesn't. That should be in the setting of trauma. I think that a scaphoid view should always be included, and there are other views in the wrist that we obtain in the setting of instability that if the instability question's asked, then we'll obtain those. But if it's standard wrist pain, then there'll be sort of a standard series of usually about 3 views for a wrist.
So in my way of thinking of x-rays, which are one of my favourite investigations, I would have considered that for any traumatic scenario or any scenario we're concerned about arthritic or bone deformity, an x-ray is the first-line investigation. But obviously ultrasound then has a role to play for further investigations after that. How can ultrasound complement x-rays in general?
The benefit of ultrasound is obviously its ability to assess the soft tissue structures in a periarticular location, and also to be able to assess them dynamically. Ultrasound has its other value in the sense that the radiologist in particular gets to have a chat to the patient, find out what their issue is, and try to address that with the appropriate images. So often the images taken aren't necessarily a standard series of images that you've got a view of this and a view of that. It's actually just trying to represent what the presentation is. Ultrasound is a very good modality. It's obviously very user dependent, but the technology is unbelievable. And what most people don't realise that for a lot of things, ultrasound is better utility than MRI in the right hands. So there are some areas where MRI is definitely better, but for some things I'd much rather use ultrasound.
Now there's different types of ultrasound, aren't there? I believe there's the colour Doppler ones, which are useful in vascular. Do they have any role in orthopedics?
In the day-to-day musculoskeletal practice, we use a form of colour Doppler to assess for microvascular flow. And we see that a lot in areas where there's inflammation. So if there's synovitis, we may see some synovial thickening. But if we see some hypervascularity as well, we tend to imply that that's an inflammatory or more acute synovitic process. We also look for vascularity in and around tendons. Most of the time when you look at a normal tendon, or pretty much every time you look at a normal tendon, the tendons should be avascular, so we'd see no internal vascularity. But in the setting of tendinosis, there's often quite prominent hypervascularity. We use that as a way of grading the level of tendinosis and the likelihood of symptom pathology. So we see vascularity obviously in and around the surface of the bone and periosteum when we're looking at the setting of stress fractures. So it is actually quite an important tool in assessing of the musculoskeletal patient and to try and determine what the source of their current symptoms are. Is there anything else that we use in musculoskeletal? For the most part, it's a dynamic assessment. It's a matter of understanding the anatomy, determining what is abnormal appearance, and often some things that are abnormal aren't necessarily symptomatic because often what we're imaging is part of a normal aging process. So that's where obviously the clinical examination, the history, being able to push on the area and determine whether it's tender is important in the ultrasound examination. The colour Doppler we use again to try to determine if there's any sort of acute inflammation. And obviously you can move the part when you're looking at things that may flick over themselves or snap, then actually being able to assess the structures as you're moving it and going through the range of motion is quite useful. You're able to see bursts, hinge, you're able to see osteophytes. There's lots of values in ultrasound in that regard. With elastography that most people wouldn't have come across, which is a form of ultrasound where you're looking at the elastic properties of tissues. And it does have quite a significant musculoskeletal role, but that's mostly still used in an academic setting and less so clinically because most of the time it doesn't really add anything to our general day-to-day clinical diagnosis.
So really ultrasound, in summary, would be a great way of actually getting a chance to actually speak to the patient. And if you've got interest in musculoskeletal radiology, then that's when it really takes off. Then you can also assess for signs of inflammation, which may not be obvious on examination straight off. You could also look for collections and also for subluxing tendons or other abnormal pathologies such as osteophytes, etc. So it really has quite a bigger role than just purely diagnosing a fluid collection and aspirating, I believe.
Oh, for sure. Its role in assessing of nerves is certainly greater than that of MRI, particularly when we're talking peripheral nerves. Deep nerves such as those in and around the spine are better assessed with MRI, but if you're assessing the median nerve or the ulnar nerve, ultrasound's a better way of determining whether the nerve's abnormal or otherwise. And a lot of the superficial tendons can probably be better assessed with ultrasound than MRI. Fingers and the ligaments if you can see them on ultrasound, you'll get a better view with an ultrasound probe than you will with MR. So it has quite a significant role in musculoskeletal. You're correct. It's a great way to add to your musculoskeletal skills by actually seeing the patient, seeing their presentation, and finding out what their issues are. So.
And I presume it's less concerning for the patient not being placed in a MRI machine, and also reassuring for the patient. It's quicker too, I presume.
Yeah, typically it's quicker, a lot quicker than the standard MRI examination. But with some complex issues, we might spend 10, 15 minutes scanning various things on ultrasound, trying to elucidate what the course presentation is. On occasion, I will have to do a block on a nerve of concern. If you think the lateral femoral cutaneous nerve is the size to cause the symptoms, you might block it and then wait for a period and then retest it to see if it makes a difference to their symptoms. So there is partly a clinical assessment that's going on with musculoskeletal ultrasound.
So it can take a lot longer than an MRI in that scenario.
It can if you have that setting.
I suppose it also has the advantage also having intervention at the same time.
Yes, that's certainly one of the huge benefits is being able to do the injections and direct the needles in the correct location. You would have thought putting a needle in somewhere and trying to see it with ultrasound would be a fairly straightforward technique, but there's actually a fair bit of skill involved. It's crazy how hard sometimes it is to be able to find a needle when you're going for a deeper structure with ultrasound. If you're just slightly off the angle, the needle will disappear from view completely. So there is some skill in it, but it's certainly one of the main roles of ultrasound would be accurately placing injections in the appropriate locations and determining when they're necessary to occur as well. Because there are plenty of people who send along who the request is for an injection, but then when you get to chat to them and you work out what treatment they've already had and what the ultrasound findings are, you'll realise that the injection may not always be appropriate, and in those settings it's probably best not to do it and send them back for further clinical review.
So progressing from ultrasound, the next investigation I consider as a CT scan is the next one up the line. I've always considered this one as a great way of assessing fractures, but what are the other advantages?
CT in the musculoskeletal system has obviously important in patients who can't have an MRI for various reasons. So assessing the lumbar spine in someone with a pacemaker or who happens to be claustrophobic, that's a reasonable reason to do a CT. The assessment of complex fractures in the setting of a Lisfranc injury in the foot or an acetabular fracture or some of the complex fractures in the elbow and shoulder, just defining the anatomical extent of the fracture and the alteration alignment that's occurred with it, I think that's probably another key. When else do we do CTs? We use CTs a fair bit for injections, but guiding a needle into deeper locations, so particularly in and around the spine, forming foraminal injections. CT is a useful technique in getting the needle in the right spot and being confident that the needle is in a appropriate location, non-vascular location, not in the intradural space. I think CT is the best modality for making that assessment. We also use CT for workup of patients for pre-surgery. So there's plenty of CTs done for assessment of limb rotations and limb abnormalities for workup of hip replacements and knee replacements. So they're probably the main reasons forming a CT. And on occasion we might do them in those patients who there's a potential for an X-ray occult fracture and you think, well, if we perform a CT we may be able to see it. That's another reasonable indication to perform a CT.
Yeah, exactly. You'd remind me of the 3D films you can produce or images you can produce to help guide our surgery. We often use them for producing 3D blocks for helping us position the guides in for either doing a shoulder replacement or knee replacement or hip replacement. So they can be quite useful that way as well. The next investigation, obviously, MRI scan, the new kid on the block. When I was growing up, they weren't even around. I remember them coming through and around about the end of the 90s. Would that be about right?
Look, I think it's probably more mid-80s to late 80s that they sort of started appearing.
So the technique is to magnetise the body, and when it demagnetises, it produces a radio signal. Is that correct?
Yes. So what a lot of people don't realise is the magnet is always on, and the concept is in going into the magnet, the people's protons when they're in the body, when the majority of their protons are hydrogen ions in water, which obviously makes up a large part of the human body. And so they all align along the axis of the magnet with the positive and negative end of the hydrogen ion following the magnetic field. And then to obtain an image is essentially relates to sending in radio frequency pulses into the body, and then with that, the energy of these radio frequency pulses causes the hydrogen ions to flip out of alignment with the axis of the magnet. And then on returning back to the position of the axis, the energy is released, and that energy is then collected and its positional data is obtained. And how fast that energy is released is an important part in determining the signal intensity that we ultimately ascribe to the region in the volume. And then that's essentially a very basic description of how an MRI is obtained. So.
And there's different sequences you can do to give different pictures, is that correct?
Yeah, look, there's lots of different ways in which an image can be obtained. Some are faster, some are slower. The classical descriptions with regards to MRI sequences have always sort of based themselves around T1 and T2 weighted sequences, and they're not obtained at the same time. They're obtained from using separate sequence design, and in a sense you're putting on a pulse and then you're obtaining the echo at a certain time. And it's that information and how long you give the echo charts to decay will ultimately determine what sort of signals you're obtaining. And from that, you're going to acquire your T1 and T2 weighted images.
So from an orthopaedic point of view, I always think of the T1 as giving us a bit of an idea of anatomy and T2 for giving us more signs for fluid and inflammation. Is that correct, or is that just too simple?
Yeah, I think that's fairly basic thought about it. I think in orthopaedics and musculoskeletal imaging now, the images that we see that are bright, where the fatty components to the body, such as marrow or the subcutaneous tissues, are white. That's where the fat is essentially bright. Now, those sequences typically will have no fat suppression on them, and they may well be a T1 weighted sequence, but often today we use what we call proton density. And proton density is really a T2 weighted sequence, but it's a very early echo of a T2 weighted sequence. So most of the musculoskeletal imaging we do now is with just purely T2 weighted imaging. So it's a proton density image, and then it's typically another proton density image with fat suppression. And the fat suppression essentially makes any of the fat signal intensity go dark, and hence it makes the fluid structures stand out brighter because of the altered dynamic range that occurs by removing that very bright structure from the image itself. So we have proton density, which has a lot of anatomical images, anatomical information, and then we have the fat suppressed image, which has a lot of pathological changes. Trying to spot the bright fluid is the key.
I'd like to let you know that Aussie Med Ed is supported by HealthShare. HealthShare is a digital health company that provides solutions for patients, GPs and specialists across Australia. Two of HealthShare's core products are Better Consult, a pre-consultation questionnaire that allows GPs to know a patient's agenda before the consult begins, with the aim to reduce admin and free up time during a consult, and HealthShare's Specialist Referral Directory, a specialist and allied health directory integrated into GP practice management software, helping GPs find the right specialist. You can find out more from healthshare.com.au. That's an interesting point. That's something I never knew, so I'll be looking forward to quizzing my registrars on that next week. The other question that comes to mind, and patients always ask me this, is why is it so noisy and why do they take so long?
It's a process of waiting for the echoes to return, and then obviously you have to continually fly the radio frequency pulses and then continually try to listen for the echoes. And obtaining the echoes from multiple different regions in the body and then multiple slices all has to sort of occur. Some of it's occurring simultaneously, but often a lot of it's occurring in series. And so you're obtaining information from one slice and then from the next slice and then from the next slice. And each occasion trying to obtain data from various voxels, which is the small little unit of information that we're getting signal back from. If you compare it to, say, CT, where we have an X-ray source at a particular slice, and then as the detectors collect that X-ray source, they're obtaining information on the entirety of the volume that's in that slice. MRI obviously has to obtain it a lot slower and wait for the echoes and the signal that occurs from the relaxing protons. The noise is essentially the shifting of the radio frequency. So there are a number of coils that create the differences in the magnetic field, and one has to create a difference of the magnetic field along the length so that one can essentially create a difference between what a proton looks like in one slice from the next slice. And switching the gradients is essentially switching the magnetic fields, which allows for the radio frequency to be obtained. So switching it on and off is part of what makes them so noisy. And some sequences are fairly loud because there's really quite swift and quite large differences in the switch, and others are less so.
What about any new modalities that might be developing? Anything you've heard on the pipeline that might come out that's we've not heard about it yet?
I think the things that have probably changed the most lately is the functional imaging, which is occurring with nuclear medicine and being able to radio label lots of different chemicals and then being able to detect those in different parts of the body. PET scanning is probably the big thing that's certainly occurring in cancer imaging more than anything else at the moment, and detecting metastasis or early cancers. I think that's a big part of what radiology has sort of gone forward in over the last 5 to 10 years, I suspect. And combining PET scanners with CT scanners and combining PET scanners with MRI has also been something that's been occurring at a large number of institutions. But again, a lot of that's for oncology imaging or sometimes for neurofunctional imaging. and it's not something that I routinely do on a day-to-day basis. Other things that are probably going to make a difference in radiology in the long term is probably artificial intelligence, and where a lot of work's been done on machine learning to the interpretation of X-rays and CT scans and for detection of abnormalities that are potentially subtle or easily missed, such as in mammography. It seems to be going fairly slow, but with most things in the computer world, they seem like they're going slow, but probably a lot more happening in the background that we're yet to realise, and then suddenly it's upon us and the whole world has changed. So
we'll have to watch this space. It's certainly a couple of things I have heard about. One question put through to me by a medical student was the role of investigations for closed head injuries. It's obviously quite big at the moment with concussions in sport. After the physicians assess the patient and decided they have had a concussion, if you are concerned about any major injuries, it's a CT scan for acute serious injuries and an MRI for long-term axonal injuries.
I think that's probably a reasonable way to look at it. I think detection of acute hemorrhage, particularly subarachnoid hemorrhage, but just acute hemorrhage in general, is probably easier achieved on a CT scan than on an MRI. And in the acute setting, it's obviously a lot easier to obtain a CT scan. So the things you're looking for there is evidence of hemorrhage or extradural hematomas, skull fractures, subdural hematomas, cervical bone fractures. So in the acute setting of a head injury, a CT is reasonable if it's a significant injury. MRI, there'll be plenty of people who have sort of extended symptoms from a concussion and they may end up having an MRI just to make sure that there's no additional damage done. Frequently these are going to be normal, but they're still done quite regularly. Someone who's had like severe head injury where they've had diffuse axonal injury, etc., that there'll be chronic changes on their MRI. And they're things that we look for in that setting. But those people are, they tend to be fairly obvious that there's been quite a significant head injury at the time.
We've covered a lot. Last question, I think, the medical student coming through and wanting to assess an X-ray. We all remember those days where we'd stand in front of the X-ray and the consultants asked them to have a look at it. What's the easiest little mnemonic or little? I like to use rule of threes. What's a little list of things to think about to help them get their head over what they're looking at, and how would you describe looking at a wrist X-ray or a knee X-ray? What's the first few things they should do?
Well, look, I think one of the things we were always taught when looking at X-rays is the key is to work out what's been X-rayed, who's been X-rayed, is it the person you believe that you're looking at? So checking the name, checking the date, being sure that the X-rays you're looking at relate to the current presentation of the correct patient, making sure you're looking at the correct side, so looking at the side marker is obviously is probably the key. And then beyond that, then you start to looking at the images themselves and obviously determining whether they are appropriate image quality so that there's no movement or significant artifact. And then beyond that, it's determining what's normal for this individual. So is this a discretely immature individual or mature? Are those lucencies, physes, or are they fractures? And then essentially, if we're talking about a joint, I would probably focus on the joint spaces, the bone alignment, the bony appearances for bony lesions, surrounding soft tissues, looking for evidence of osteoarthritis, looking for evidence of trauma, and then looking at the soft tissues for osteochondral bodies, soft tissue calcification. And there are a lot of soft tissue changes such as bone effusions and just general prepatellar swelling or etc. that you can actually detect on X-rays, even though it's probably not the best modality for making soft tissue assessment.
I think one of the things I see from medical students is everyone sees the obvious and then starts thinking that's so obvious they'll talk about the other things that aren't as obvious first. But it's always important to mention, once you've checked the date and the name of the patient, state the obvious first off.
I agree. You can spend a long time talking about the normal structure. They just want to know what's causing their knee pain, and they've got a knee, and that you can, if you're assessing it, determining what the cause of their discomfort is. It medial compartment osteoarthritis, or is it gout within the medial collateral ligament? All these things, you can make a determination, and that's what should be within your bulk of what you're talking about when you're making that sort of assessment.
Excellent. Look, it's been fantastic chatting to you. It's obviously an unusual way of doing radiology on a podcast without images to look at. It's great to hear about the different modalities and what's coming up. That's why I thought it'd be useful in this, and I really appreciate your experience.
No worries, Gavin. Thank you for the invitation, and hopefully people got something useful out of it.
Yeah, thanks very much, Shaun. Shaun Fowler. The information provided to you today is designed to complement the information provided to you in your local region and should supplement your readings and teachings in that area. Please don't take it as the only way of treating this condition or assessing a condition, but really as one of various ways of assessing these conditions. Please also be aware that the information provided today is really just general medical advice and isn't designed to actually be a source of medical information regarding your particular condition. Remember to consult your specialist or medical practitioner if you have concerns about a condition raised in this podcast. Well, thanks once again for listening to our podcast, Aussie Med Ed, or the Australian Medical Education Podcast. We really enjoy hosting this podcast. I hope you find it useful to hear a pragmatic approach to everyday conditions. If you have any questions or information you want to ask about us, or you'd like to put a suggestion for a topic, please don't hesitate to email us at gavin@med-ed.com.au. Once again, I hope you've enjoyed listening to it, and we look forward to hosting it next fortnight when we introduce a new topic. Thank you. Aussie Med Ed is proudly sponsored by HealthShare, a digital health company that provides solutions for patients, GPs and specialists across Australia, and Tego, offering medical indemnity insurance for doctors. That's tego.com.au.